Are you ready, RD?
Good morning, Excellencies, delegates and colleagues, and welcome back to our final day of the 76th RCM here in Fiji. And before we start, may we request the representatives to complete the feedback survey that the Secretariat has prepared using the QR code that will be flashed on the screen. We will be giving you a few minutes to access the survey. The Secretariat will also email the survey to Member States to allow those who joined but had to leave early to be able to provide feedback as well. And I thank you very much. And before we proceed with the next agenda item, I would like to report to the plenary the outcome of discussions of yesterday's private consultation with Member States, as well as the closed session of the regional committee meeting that took place at 11 a.m. On the one executive board seat that will be vacated by Australia in May of 2026, the Western Pacific region will propose China. Regarding the offices for the 79th World Health Assembly, Papua New Guinea will be proposed for Vice President, Indonesia for Vice Chairperson for Committee B, China and Fiji for General Committee, Mongolia and Vietnam for Credentials Committee. Thank you. So now we are very close to the end of our week, as I had mentioned, but we have a few key items remaining to consider today. For efficiency's sake, I would like to propose an alternative approach to the morning. We will resume agenda item 14, where we will still have 14.2, hypertension control, 14.3, safer surgery, and 14.4, tobacco control. To help us move these faster, we will take the presentations on these three items together now. Following this after coffee break, we will open the floor for those three sub-items together. And I encourage you to either combine your interventions. I will allow 4 minutes to make one on the floor, and submit others for written intervention. Or you can combine 3 and try and deliver the interventions within 4 minutes. This will be posted on the RCM portal for the written intervention submitted to the committee. Philippines.
Thank you, Chair. We agree with the recommendations.
So I see head nodding and agreement around the floor, so I believe we will proceed with that recommendation. And the 4 minutes is also cut across the Member States and the Secretariat as well. And may I call on Dr. Susan Mercado, Director of Program Management, to introduce this.
Thank you, Chair, and good morning, everyone. It's my pleasure to introduce the technical discussion on hypertension. And we're going to start with a Slido. Let's see if we can get that up the screen. I think there was some opportunity to have your blood pressure taken this morning. And okay, let's see. The question was, what's your most recent blood pressure reading? And you have a little piece of paper in front of you, which you can use to get the QR code. And then you can join Slido at RCM, hashtag RCM76. So let's take a look and see what the blood pressure of the group looks like. Okay, we're going to keep the Slido open. Please key in your blood pressure. So far, it looks like everyone has their hypertension or their blood pressure under control, and we'll proceed with the presentation and give you the results at the end of this particular topic. Go ahead, Dr. Hong.
Thank you very much, Dr. Mercado. Honorable chairs, distinguished representative. It's my great pleasure to present to you as this technical discussion on hypertension. In the next few minutes, we will explore the urgent challenge of hypertension, including its burdens, gap in care, the target we aim at, and the way forward to address this significant public health problem to make a difference for millions of people in our region. Next slide, please. I would like to begin with the big picture. The majority of countries in our region are not on track to achieve the Sustainable Development Goal 3.4, reducing premature mortality from non-communicable diseases, or NCD, by 1/3 in 2030. As you can see, the probability of dying from the cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases below the age of 70 remains unacceptably high in many countries, accounting for more than 75% of all mortality in our region. While we have made remarkable improvement in communicable diseases services coverage through effective public health programs, the progress on NCD, including hypertension, has been much slower. Services for non-communicable diseases barely improved over the past 2 decades. This gap put millions at risk and highlight the need for urgent actions. Hypertension is the #1 risk factor for global disease burden. According to the Global Report on Hypertension in 2025, estimated for 1.4 billion people aged 30 to 79 suffer from hypertension, and this figure is 403 million in our region. Yet, less than 20% have the condition adequately controlled. Hypertension contributes for more death and disability than any other risk factors. Over 10 million deaths annually worldwide. It is a major contributor to heart diseases, stroke, kidney failure, and other NCDs. What is especially concerning is that hypertension is often silent and undiagnosed, particularly in low and low-middle income countries. Yet, effective control can significantly reduce premature mortality and improve quality of life, as well as reduce financial burdens on families, health systems, and economies. Let's look at some country example. In the Philippines, 34% of adults have hypertension, but only 17% have it under control. In the Republic of Korea, prevalence is at 27%, control rate is higher, 57%. In Tonga, prevalence is tracking at 47%, but only 10% have their blood pressure control. Countries continue to face significant challenges and barriers, such as limited resources, fragmented service deliveries, limited access to medicine, and disparities in healthcare access that hinder the effective implementation of hypertension prevention and control strategies. With the overall 29% prevalence in the region, many people with hypertension are not aware of the health status or not receiving adequate treatment. Currently, only half of people with hypertension are diagnosed, and less than 50% of them are treated, and even fewer have their blood pressure controlled. Our goal is ambitious but achievable. By 2030, we would like to diagnose 80% of all people with hypertension, treat 80% of those diagnosed, and achieve adequate blood pressure control in 80% of those under treatment. This would mean 100 million more people with controlled hypertension in our region, and these targets will increase in absolute number when we welcome Indonesia in our region. Here you see the trend in diagnosis, treatment, and control across the countries. While some countries are making progress, most of them are far from the 2030 target. Currently, only one country in our region, Republic of Korea, has achieved this target. The Western Pacific region vision for 2025-2029 is to weave health for families, community, and society. One of our key deliverables is to increase the number of people with controlled hypertension by 100 million. This is a bold commitment, and it requires a comprehensive approach with transformative primary health care as the foundation to achieve this goal. The WHO Heart Technical Package provides a standardized modular approach to deliver high-quality hypertension and cardiovascular diseases care through primary health care. It covers healthy lifestyle counseling, evidence-based treatment protocols, access to essential medicines, risk-based management, team-based care, and robust monitoring and evaluation system. So what makes a hypertension control successful? First, we seek to strengthen the policy and governance frameworks to embed hypertension control into national NCD strategies and broader health system reforms, including primary health care and universal health coverage. Second, to promote effective health promotion and prevention policy to address risk factors such as unhealthy diet, tobacco, alcohol, physical inactivities. Third, we need to integrate hypertension services into primary health care, which include health promotion, prevention, screening, treatment, and monitoring and follow-up, and the use of standardized treatment protocol heart technical package. Of course, we need to improve the access to essential anti-hypertensive medicine with an affordable price and support the adherence and continuity of care, and thus enhance monitoring and evaluation and utilization of digital and innovations. Across the region, countries are taking action and making progress in addressing hypertension by embedding hypertension control in primary health care and other NCD prevention management. I would like now to invite you to watch the video on tackling NCD in Solomon Island. Please show the video.
In 2011, Solomon Islands declared NCD a national crisis. At least 12% of all adults in Solomon Islands have diabetes and 26% have hypertension. Each year, they're responsible for $90 million in healthcare, productivity, and other social costs. This is 6.3% of the country's GDP.
Uncontrolled diabetes and hypertension are the leading cause of mortality, morbidity, as well as disability here in Solomon Island.
Over the last few years, I've seen the number of diabetic foot infections increasing for it to occupy up to 60% of the surgical beds in the hospital.
Globally, health worker training is done everywhere, but unfortunately, it is common for health workers to return to health services without changing their practices. A national baseline assessment in 2024 found that of all diabetes cases, 8% were managed correctly. For diabetic foot cases, 11% were managed according to national standards. For hypertension, 43% of required clinical tasks for blood pressure measurements were done correctly, and less than half of clients were told their blood pressure status. Innovative methods can build on previous efforts to strengthen primary care practices. This program, championed by Solomon Islands Ministry of Health and Medical Services with support from the World Health Organization, targets this crisis with a strategic approach, beginning with coaching.
Coaching have no involve PowerPoint presentation or handouts. Saya asking question, me fala answer, and saya more involved inside. So time I go back, also me no needing book for read, but also stay low, think long panang.
Coaching key practice skills was just the beginning. Even as knowledge and skills improved, several barriers at the clinic level made it difficult to apply the standards consistently. This is where quality improvement was introduced. To improve diabetes, diabetic foot, and hypertension screening and management, clinics made 6 key changes. Health facilities are now decluttered and reorganized, creating more functional space. Everyone over 40 years old is now screened. Tasks are split across stations, allowing staff to care for clients simultaneously. Foot screening is now routine for all diabetes clients for early detection and management of risk factors to prevent amputation. Updated NCD registry book to align with national standards. A tracking system to contact clients for their follow-up to enable a timely return.
Quality improvement, hembara help mo tanesis po save do ma waka properly. So tayo mo tab garan bisala ownership for this program na o tanesis o actively participate for sorting out own areas bloketa.
Clinical indicators improved significantly in the first year of the program. In early implementation clinics, the number of clients screened for diabetes and hypertension increased by over 7 times. Detection of new diabetes cases increased by 4 times. Diabetic foot screening was received by hundreds of clients who had never been screened before. Diabetes, diabetic foot problems, and hypertension are silent diseases that often do not have symptoms. Before, screening was not routinely done, and high-risk clients were often missed. Now, almost all clients receive the screening package for these conditions. By identifying problems early, health workers can help prevent serious complications such as strokes, heart attacks, and limb amputations.
This time, something improve. So me feel happy everything you do him, so some patient and satisfied too.
This initiative will support and strengthen the ongoing NCD program in the country.
If we can stop this epidemic of amputations that is plaguing this country, we have done something that deserves, it is a miracle what we have done. And you all are part of a miracle.
This model will be replicated to other clinics, and I'm sure this strategy will continue to save life and promote the definition of health as per the W.H.O definition.
The program is now expanding to other provinces with plans to reach the entire country, coaching more health workers and improving care nationwide.
I must sincerely acknowledge W.H.O to put my health workforce as a champion of preventing physical disability.
This progress was made possible through the generous support and contribution of our partners.
Thank you very much. Now I would like to invite the distinguished representative from Macau SIR, China, to present the Macau blueprint focusing on the population-based intervention for hypertension control. Thank you.
Distinguished Chair and Delegate, it's an honor to be here today to share Macau's experience in chronic disease management. In Macau, like much of the world, we face the growing challenge of chronic disease. Effective chronic disease management is no longer optional. It is the cornerstone of a sustainable and resilient healthcare system. Next. Therefore, the government of Macau previous slide, please. Therefore, the government of Macau SAR has developed a Healthy Macau Blueprint in 2024 to comprehensively align with and actively implement the Healthy China 2030 planning outlined. Next. We shift our policy to focus on prevention, allocate resources effectively, change our mindset, and ensure early detection, early treatment, and quality management to reduce the incidence of complication and mortality rate of chronic disease. Next. Macau's total population in 2024 is 688,000, with approximately 1 in every 7 individuals diagnosed with hypertension. Among these patients, 86.1% receive follow-up care in public healthcare institutions. Since the majority of hypertension patients are managed in the community healthcare setting, the ability of community healthcare to effectively manage this patient becomes even more crucial. Next. To effectively manage chronic disease in our community healthcare, we launched a pilot program focused on hypertension and diabetes managed at one of Macau Health Center in 2017. This program, which we call the Chronic Disease Management Quality Indicator System, it expanded gradually, and by 2023, it was fully implemented across all Macau Health Centers. Next, please. The operation of this quality indicator system employs the PDCA cycle concept from management science. This approach involves a continuous process of identifying problems, analyzing them, and implementing solutions, all aimed at achieving ongoing improvements in service quality. Next, please. First, we conduct a baseline analysis to identify issues, and we discovered 2 major problems. We see a lot of clinical inertia in adjusting blood pressure medication and prescribing insulin. The second problem is the blood pressure control rate can be vary as much as 2-fold depending on the doctors. Next, please. To uncover the reason behind the performance discrepancy, we surveyed the doctors about their confidence in managing NCD on a scale of 10. The result was striking, showing a critical lack of confidence among most clinicians. Additionally, the most significant factor influencing doctors' blood pressure control is a delay in the translation of updated clinical knowledge into practice, and their lack of skill to persuading the patient to adjust the treatment. This type of problem is likely not unique to a health center or Macau. Other regions of community healthcare may also face the similar situations. Next. We move into the problem-solving stage. We're closing knowledge gap with specialized lecture, building confidence through an internal referral system for complex case, enhancing communication skills via dedicated workshops, and most crucially, combating clinical inertia with a confidential annual performance report for each doctor, detailing their rankings and achievement rate to foster accountability and self-improvement. Next, please. After a year of dedicated efforts, we conducted a re-evaluation in 2018 and were pleasantly surprised to find that we have achieved a 10% improvement across various metrics, including the blood pressure. This progress highlights the effectiveness of our initiative, but the story doesn't end there. Next, please. During our 2019 re-evaluation, we noticed that the blood pressure control rate dropped slightly. Next. And the performance still varies significantly among doctors. Many were not showing improvement in their blood pressure management. Next, please. We dug deeper and found key issue is the blood pressure was often recorded as free text rather than in the digital structure field, and the daily blood pressure reading from patient were not being documented. Next, please. Therefore, we standardize where and how to record blood pressure and mandate the use of digital structure field. Next. And it worked. By 2020, blood pressure control rate become more consistent across doctors. Next. And show overall 9% further improvement again. Next. After 8 years continuous effort, this program has gradually expanded from one single health center to entire Macau Health Bureau. It has also broadened its focus from diabetes patients to all hypertension patients, and we plan to expand into the management of dyslipidemia this year. Next, please. This chart shows our 2024 diabetes management result. Our blood pressure control rate in diabetic patients exceeds 70%. Next. And in hypertension patients, we also saw major progress, a 14.1% increase in control rate versus 2023. This translates to over 11,000 additional patients with well-controlled blood pressure. Next. Our approach will build on 3 key points, all requiring zero additional investments, including the zero punishment approach, zero additional resource, and zero high-tech investment. Next. In conclusion, Macau's PDCA-based initiative standardized the process and sets clear targets by regularly sharing confidential performance data with clinicians. It enhanced the self-improvement and drove consistent annual gains across entire Macau community healthcare settings. This structured data-enhanced model successfully improved chronic disease outcomes and offer a replicable strategy for other regions' community healthcare settings. My sharing ends here. Thank you for your attention.
Thank you very much, the representative from Macau SAR, China, for excellent presentation. Now I would like to invite the distinguished representative from the Philippines to share the country experience on scaling up the Healthy Heart program in the Philippines. Thank you.
Thank you, Chair. The Philippines is honored to present the country's initiative in strengthening hypertension control, beginning with our Healthy Hearts program and now transitioning into a national initiative called Protection sa Presyon, or in English, Protection from Hypertension. This journey reflects the country's commitment to reduce premature deaths from cardiovascular diseases through scalable, sustainable, and locally owned health systems reform. Next. The Healthy Hearts program localized the WHO Hearts package and is now integrated into the Philippine package for essential NCD interventions, which we call PhilPen. HEART stands for Healthy Lifestyle, Evidence-Based Treatment Protocols, A for Access to Essential Medicines and Technology, R for Risk-Based Management, T for Team-Based Care, and S for Systems for Monitoring. Next, please. With the overall goal of reducing premature deaths and morbidity, the program is anchored on 3 strategies, namely, strengthening stewardship and governance, ensuring accountability and local ownership. 2, improving supply and workforce capacity, including consistent access to essential medicines and coaching of primary care teams. 3, community demand generation, mobilization of barangay health workers, and promoting lifestyle modification. These pillars ensures that hypertension care became integrated within the primary care framework. Next, please. The Healthy Hearts program evolved through 4 phases. Phase 1 focused on the development of localized WHO Hearts technical package, establishing the standards, tools, and operational guidance that served as the foundation of the program. For Phase 2, the implementation was rolled out in one of the districts in Western Visayas to test the package within communities. Afterwards, the program was expanded through 3 provinces in Western Visayas, and then the program further expanded to 1 region, 4 provinces, 1 highly urbanized city in Phase 4, demonstrating the readiness for a wider national rollout, ensuring the program is adaptable across diverse communities and islands. Next, please. The Healthy Hearts technical package has been a key driver of success in our pilot and expansion sites. We created job aids, simple, visual tools like BP checklists, flow charts, and lifestyle guides to help primary care teams, including barangay health workers, and also deliver consistent protocol-based care. To scale training, we developed an e-learning course through the W.H.O Academy with interactive modules on accurate BP monitoring, risk assessment, lifestyle counseling, treatment protocols, enabling nationwide self-paced learning and certification. Finally, the e-registry was integrated into electronic medical records, tracking patients from screening to follow-up, providing access to data across levels of care. Next, please. Aligned with the global hypertension control benchmark, the Philippines aims for 80% of adults aged 20 and above to be risk assessed using the PhilPen protocol, 80% of those with hypertension among those risk assessed to be properly diagnosed, 80% of those diagnosed to receive consistent treatment, and 80% of those treated to achieve controlled blood pressure. This unified target framework ensures that every level of care, from screening, diagnosis, treatment to control, is addressed systematically and monitored through our registry. Next. In the pilot districts, the results have been very encouraging. As of March 2025, there were 165 active patients enrolled. Among them, 74.1 have controlled blood pressure, 7.1 remained uncontrolled, and 18.5 missed their follow-up visits. Next, please. We observed similar success in Antique Province, one of our expansion sites. Of the 27,811 active patients, 70.1 achieved controlled blood pressure, 23.7 remained uncontrolled, and only 6.1 had missed visits. These findings validate the model is replicable and scalable, producing comparable outcomes even in new sites with diverse contexts. It also demonstrated the critical role of continued data monitoring in maintaining high-quality implementation. Next. Based on review, 3 key foundations sustained the momentum and enabled scale-up of the implementation. First, local governance and ownership drive accountability and integration into routine services. Second, the National Health Insurance Corporation primary care capitation-based packages ensured sustained financing of diagnostics and supply of medicines. Third, digital systems support continuity of care and real-time monitoring. Together, this forms the backbone of our national scale-up. Next slide, please. Building on these lessons, the Philippines will launch a nationwide hypertension control program campaign in 2026, named Protection Suppression, with the goal to manage hypertension in 10 million Filipino adults. It embodies a whole of government and all of society approach structured around 4 main areas: promoting health and preventing disease, delivering quality services, strengthening the systems, and ensuring good governance. The program will also promote public awareness and healthy behaviors, expand access across the cascade of care, enhance case finding, strengthen health system support, improve financial risk protection, and enhance data and information systems. Next slide. This slide shows the strategic framework and the roll-up plan of the program. The program will be implemented utilizing 4 strategies. First, the nationwide communication campaign. Then next, there will be a regional-wide screening and treatment that will standardize care using the updated Philippine package. And then there will be a synchronized screening month on February, mobilizing all facilities for nationwide screening and follow-up. And then the health systems will be strengthened, ensuring sustainable structures through medical supplies, workforce training, and digital tools. The implementation will proceed in phased stages. In 2025, preparations will be conducted. By 2026, regions will progressively roll out activities, expanding coverage and strengthening capacities. In 2027 February, a nationwide synchronized hypertension screening will be conducted across the country, and also enhance early detection. From March to December 2027, efforts will center on sustaining implementation and institutionalizing hypertension control within the universal health care framework. The Philippines is moving decisively from pilot to nationwide scale through the Protection Suppression, a unified effort that brings together policy, financing, and service delivery towards one goal: to protect every Filipino heart and achieve sustained blood pressure control nationwide. We thank the World Health Organization for its steadfast support and technical guidance throughout this journey. Thank you.
Thank you very much, the representative from the Philippines, for sharing the successful Healthy Heart program and the National Scaling Up Plan. Now, I would like to hand back to Dr. Mercado. Thank you.
Thank you very much, Dr. Tran. I just wanted to show the Slido results. We had 62 respondents, and I think we get a bit of a snapshot. So it looks like we have 73% with blood pressure equal. I think on the Slido it says equal or less than 140/90. There we go. Okay. And let's just go back to that first slide. That's the only one we need to look at right now. I think the others, we put in also the questions on tobacco control. We'll take a look at that later. But we also have those with blood pressure higher than 140/90, and those who didn't know. So I think this is probably a good snapshot also for the rest of the health sector, and we'll continue to try to understand how we can improve knowledge about blood pressure and knowledge about when you need to have more treatment or more consultation. Thank you very much. Let me turn over to the chair. Okay, thank you very much. We will proceed with the discussion on safer surgery, and my honor to turn over the floor to the regional director.
Thank you, Susan, and thank you, Chair, distinguished representatives. I am pleased to introduce this important technical discussion on a topic that lies at the very heart of our commitment to universal health coverage, safer and affordable surgery. While the title of this session highlights safer surgery, I urge us to expand our lens. Safety without affordability is not equity. Access without financial protection is not justice. So let us speak today not only of safer surgery, but of safer and affordable surgery for all. We know that essential surgical procedures are among the most cost-effective interventions in healthcare. Globally, they could prevent up to 1.5 million deaths each year in low and middle-income countries. But beyond the numbers, every safe surgery performed is a life saved, a family preserved, a community strengthened. In 2020, this committee endorsed the Action Framework for Safe and Affordable Surgery in the Western Pacific region, 2021-2030. That framework laid out a bold vision to embed surgical care into the fabric of our health systems, not as a luxury, but as a necessity. Since then, member states with support from W.H.O. and partners have made commendable strides. We've seen system-wide improvement, better use of data to drive decisions, and growing investment in capacity building and multidisciplinary teamwork. But the work is far from done. Today, I invite you to reflect on three critical priorities. First, sustainability. How do we ensure that the gains we've made are not short-lived, but embedded into the DNA of our health systems? Second, equity. How do we guarantee that surgical care reaches everyone, regardless of geography, gender, or income? And third, integration. How do we ensure that surgical services are not siloed, but fully embedded in essential health packages, national strategies, and primary health care? We look forward to hearing your experiences, how you are strengthening surgical safety by linking it with emergency, critical, and operative care, and how you are integrating these services into broader health system reforms to reduce preventable deaths and ensure no one is left behind. Let us remember, surgery is not just about operating rooms and instruments. It's about dignity. It's about access and the right to health. It is about ensuring that a mother in labor, a child with appendicitis, or a patient in trauma can receive timely, safe, and affordable care wherever they live. With that, it is my pleasure to hand the floor to Dr. Susan Mercado to moderate this technical discussion. Thank you, and over to you, Susan.
Thank you very much, RD. I think we have a presentation from our technical director and two countries that are going to present, so let me turn over to Luis.
Thank you very much, DPM. Good morning, everyone. Slides, please. This presentation has three blocks, and I would like to go through them. First will be why safer surgery? Why do we need to bring it to our collective attention? The second is what will trigger the action, and what is the approach that we are collectively doing. And the third one is a snapshot about progress before we give the floor to two member states. Next slide. That's a very important metrics. Perioperative death are the third leading causes after ischemic heart disease and stroke. And as RD was mentioning, there is well-known evidence-based cost-effective interventions that could help avert 1.5 million lives in low and middle-income countries. Next slide. In a recent Lancet Commission report, it was estimated that globally 5 billion people lack access to surgery and anesthetic care. And WHO, in a WHO resolution in 2023, aim at bringing integrated emergency, critical and operative care for universal health coverage as part of our agendas and pushing our member states to act on. Next slide. Our approach in the Western Pacific region is try, as RD has mentioned, not to approach it in a siloed way and bring it as part of the health system's strengthening support and in particularly primary health care. Next slide. And just to give you an example of what exactly will mean and strengthening safe and affordable surgery as part of strengthening systems. It will mean upstream work, including surgical interventions on health benefit package, includes improving supply side readiness while making oxygen supply, electricity and water available on facilities, on improving referral systems and the way how services are organized, on making sure that we have skilled health workers everywhere that can provide a list of interventions, including surgical interventions, and increase the battery of quality improvement tools, including checklists, bringing patient voice, etc. And as you see the last picture, and with the example we heard from Dr. Huang, engaging communities also on being the first eyes to support preventing and avoiding that these cases arrive at the operation theater. Next slide. So, 2 slides to share a bit what are the key findings of a benchmarking survey that we have done this year on the progress of safe and affordable surgery in our region. In the first key finding, looking at patient safety measures, 40% of our countries, or the countries that have report, have WHO surgical safety checklists at first level hospital. These checklists are very important when aiming at improving quality. 70% of the countries have developed legal protection. This is very important, particularly to enable and to build on a culture where errors are reported and providers are comfortable doing so because they know that will be protected by the system. The second, when improving with the aim of improving data availability, 40% of countries monitor perioperative mortality rate and 50% surgical site infections. Data is important if we want to monitor progress and act upon. Next slide. The third key finding is on the supply side. 60% of the countries have reported that the first level hospitals have supply of oxygen, which is critical, and 70% which have improved on data ability of the numbers of health workforce for surgery. The last one, 60% of countries reported policies or protocols requiring written informed consent of all surgical procedures. It's important to bring voice of users. And 80%, as I said, linked to primary healthcare strengthening, have reported the interventions are included in the UHC benefit package. Next slide. That will be my last slide. Just to bring a few concrete examples on progress in some of our member states. In Kiribati, on patient safety, has established a routine patient feedback and continuous safety improvement mechanism. And many Pacific Island countries have established clinical governance mechanisms in hospitals. When it comes to improve policy and monitoring and for improvement, Cambodia has conducted a nationwide situation analysis and database national strategy development. In terms of improve on availability of resources and infrastructure, WHO safe surgery checklists and sterilization audits and programs for capacity development and environmental improvements have been introduced in several countries. And lastly, Fiji, Solomon Islands, and other countries developed and updated essential health services package on including surgical care. This is a fundamental effort to make sure that the cost-effective interventions that we mentioned to save these 1.5 million lives are included and prioritized in resource allocations. Next slide. And with that, I would like to give the floor to go deeper on 2 of the other member states that have moved particularly in this agenda. And I have the honor to invite the representative of Cambodia to share their insights. Over to you.
Honorable Chairs, thank you very much for the opportunity to present the experience or the current state of the surgical performance in Cambodia. On the next slide, please. This is my presentation will be cover 5 points. For the key socio-economic indicators, second system performance, third surgical performance, fourth key feature of the national policy and the strategic plan for SOA and the closing message. And the next slide, please. These the key socio-economic indicators. I just want to highlight 3 messages. The first one, if we look at the population age structure, Cambodia is relatively young countries. And the second, with the annual growth rate of 2.1%, indicating that the population continue to grow. And the life expectancy at the 76.6 according to the interpopulation census survey last year. And this also indicated the Cambodia is on the way to the aging society in the next 2 decades. And but poverty, the poverty rate remained high, 17.8% in 2019. And Cambodia will our vision 2030 is to reach the upper middle income countries. And next slide, please. You see the health system. You see the 3 levels of the health system. I think for the first level, we call this operational district level, which consists of the referral hospital and the health district hospital and the health centers. And we have around 1,305 health centers, and 96 district hospitals, which include the 61 CPA1 complementary package of activities, and also the certified complementary package of activity level 2. We classify the hospital in 3 categories. CPA1 do not have any surgical services. CPA2 has the surgical services with general anesthesia, and up to the CPA3. And CPA3 hospital, basically all the provincial hospitals, and the national hospital, the CPA3+. And I think if we look at the capacity of the hospital delivery, the hospital bed density is 0.96 bed per 1,000 populations. Which, if we include the private health facilities, so the ratio will go up to 1.7 bed per 1,000 population. And for the health center density, we have around 13,000 population per health centers. And the ratio of doctors, specialists, and midwives to 10,000 population is 31.8. If we compare the global ratios, 44.5 to reach universal health coverage, I think it is far below the globals. And with regard to the basic and the comprehensive, the emergency obstetric and the neonatal care facility, I think Cambodia generally meet the global standards. On the ratio, but we need to strengthen the readiness of these facilities. Next slide, please. You see the highlight common indicator we related to the maternal and child health, and also related to the surgeries. So this is the trend of the maternal mortality ratios, and also the trend of the day-old mortality and undefined mortality ratios. And also Cambodia, we progressing toward the UHC coverage. The government has been set a clear target for the reach UHC 2035. This is the current the result of the UHCs. Next slide, please. Let's go to the most important part of my presentation, that's the physical performance. In 2005, we conducted the first national assessment of the safe surgery assessment. So we look at in 2005, we have around more than 500,000 cases of the surgical operations. So the palliative surgery around 6%, major surgery 23%, minor surgeries around 30%, and cesarean section is 5.8%, and the others, and the laparotomy around 3.8%. But this percentage varies significantly between the hospitals across the country, as you can see on the maps. So if we look at the figures, the different level of the surgical performance across the hospital indicate the different level of investment, the different level of resource available in each hospital, and also the different availability of services in these hospitals. Next slide, please. So this will be the other indicator that we look at the unmet need compared to the Lancet indicator. Generally, the result is the unmet need is high across the indicator as compared to the target. So for example, the infrastructure, the current assessment is only 26 compared to 100%. And the other, like the SOC workforce, the workforce availability, surgery volumes, surgery operation room, medical, electronic medical records, SOA committee use W.H.O checklist for the OT and also health facility with methodology. If we look at the result of the assessment, we need a lot of the further to improve the current performance of these key indicators. Next slide, please. So let me highlight some of the current and future reform. We use the system approach for the quality and safety improvement in surgical care. The further governance structure for the SOA. So we already established a national committee for the SOA, and also we established the working group, the international and provincial hospital. And in the near future, we will establish the SOA team at the district and the private hospitals. Second, we continue to strengthen the policy and the guideline and the practice compliance. We have developed a number of the key policy and the guidelines. For example, the national policy, safety policies, a guideline on referral care, the guideline for the patient safety beyond the surgicals, promote and scale up the W.H.O safety checklist. We improve the LDR to the protocol on sterilization, and also we implement the antimicrobial stewardship programs. With regard to the multidisciplinary or the multi-level coordination, we had the coordination team of surgeons, the oncologists, and the emergency cares. And for the capacity meeting, the hospital management had hold the weekly meeting with the ministers in order to improve the quality through the problem-driven adaptive adaptation, PDIA cycles. And we also upgraded emergency and surgical services in 2021 district hospital. That this construction or renovation will be completed by the end of this year. And finally, we developed the national policy for the strategic plan of SOA 2026-2030 in order to guide the sustainable development and investment for the SOAs. Next slide, please. We use the WHO frameworks to guide the development of the national policy and the strategic plan on SOAs. As I highlighted in the screen, I'm not, because of time, I'm not read all these frameworks. Next slide, please. So our national policy and the strategic plan for the SOA 2025-2030, our vision is to achieve safe, quality, and affordable surgical care for all. And our mission is to provide safe, accessible, and high-quality, safe, timely, and affordable, comprehensive surgical, obstetric, and anesthetic care to all peoples. And our goal is to improve the surgical, obstetric, and anesthesia system. So this policy and the strategic plan has been aligned with the Cambodian health sector vision and priorities. In particular, the government priority for the human capital investment, the Cambodian UAC Roadmap 2035, Cambodian SDGs, and also the Health Strategic Plan 2025-2034. Next slide, please. This is the strategic framework for our strategic plan 2025, 2035, not 30. So we use this framework also to guide the development of the visions, the goal, and also the strategic objectives, as well as the strategic priority for the national policy and the strategic plan for SOS. Next slide, please. This is the priority for the national policy and the strategic plan. First, we focus on the strengthening primary health care system, and also the referral for the continuum of surgical care. Second, we continue to improve the safety via W.H.O checklist. Third, we enhance financial protection and reduce the OOPs. Fourth, we expand the access to essential life-saving surgeries. Fifth, the train and deploy surgeon, anesthetists, and also obstetricians equitably. And lastly, the strengthening hospital leadership, safe culture, continue monitoring, improvement cycles. Next slide, please. So this is our commitment at Cambodia. We continue to commit to ensure that the safe, affordable surgical is available for every institution, everywhere, without financial hardship. Thank you.
Thank you very much, Cambodia, for this very comprehensive presentation where you present great analytical work on the area of surgery and affordable surgery, but also the framing it within the overall health systems and strengthening of strategic efforts. Now, I would like to give the floor to the distinguished delegate from the Solomon Islands, which is going to be present on also on the diabetic foot challenge, which, as you will see, will fit very well with the previous presentation when looking at NCD and prevention efforts also in the Solomon Islands. The floor is yours.
Thank you, Dr. Lois. Before I begin, I want to get us into a quote by saying that surgeon, like our very own regional director, would know when to operate and know when not to operate, ensuring not to do harm. We'll present on reducing burden of amputation on surgical services in Solomon Islands. But first, I want to sincerely acknowledge our partners, especially Dr. Sobel and the team of WHO in our countries, New Zealand, and other partners that are assisting us on this journey. In this talk, I will briefly discuss how Solomon Islands is tackling its high rate of diabetic amputation on our on foot wound problems. Next slide, please. The burden from diabetes-related surgical procedures in Solomon Islands is considerably. On average, 60% of surgical beds in the National Referral Hospital and provincial hospitals with surgical beds at any given time are occupied by diabetic foot cases. At least 401 major limb amputations were done between 2018 to 2023. The average hospital stay for an amputation cases is 40 days, which has a significant cost to both the healthcare system and as well as family, causing bottleneck of our surgical needs. At a higher proportion of those who have an amputation die relatively soon after the procedures. Next slide, please. The high number of surgical cases related to diabetic foot is a direct result of poor prevention, screening, and management. A primary health care facility assessment in 2014 found that only a small fraction of diabetes and diabetic foot cases are managed correctly at the primary health care clinics. Almost half of clients coming to primary health care clinics had a poor glucose control, meaning that they are at a very high risk of complications or developing complications related to diabetes. In addition, 37% of clients who have never been diagnosed with diabetes had an elevated blood sugar. Previously, these clients have been outside of the healthcare entirely. Next slide, please. Reducing the burden of amputation and other foot wound problems therefore requires a primary health care approach. It is important that we improve the early prevention, detection and management of both diabetes and diabetic foot problems before they progress to more severe diseases that requires a high-level treatment. This means that we need much more collaboration between surgeons, physicians, program staff, and primary health care staff at all levels. This is a new for surgeons who do not know traditional thinking of themselves as linked to primary health care. So there are times that surgeons would forget the importance of primary health care, and they thought chopping legs is an enjoyable thing. I remember when I was in surgeon, in the hepatobiliary surgeon in medical school, it is one of the spirits that you develop is enjoying in the theater, you know, get into the bodies and then start removing. So ectomy is removal of parts of the body, which is one of the fascinating things, but then we tend to forget the essence of primary health care. Next slide, please. There are three main goals by 2030. First, to reduce diabetic foot amputation at the National Referral Hospital by half. Second, to increase by 2/3 the proportion of diabetic cases presented to primary health care clinics that have good glucose control. Third, to increase the proportion of primary health care clients receiving correct prevention, screening, and management for diabetes and diabetic foot. Next, please. We have adopted a new approach which is based on clinical coaching, not training. Coaching for diabetes and diabetic foot screening and management is a 2-day process done in a realistic environment. It is practice-focused with no lectures, presentation, and minimal readings. Simple evidence-based checklists are used to support staff to learn evidence-based practice based on soul pain. Coaching is facilitator dependent, usually with a participant to facilitate ratio of 1:3. Local facilitators are therefore very important to introduction and rollout. They have been trained at the national and provincial level. Next, please. Facilitators coach participants until all care steps are mastered. They use case scenarios and ask questions rather than tell. Participants practice many times until they achieve at least 90% of practice tasks. For wound management coaching, we have developed cheap soap feet with mock wounds. These can be debrided to practice using the scalpel. You know, there are diabetic patients that are very scared of scalpels when you start removing from their pockets. Wound management adds clinical practice in the wound clinic to build skills in actual clinical environment. Our aim is to decentralize simple wound management to primary health care clinics and area health clinics. Next, please. An online dashboard allows facilitators to enter coaching data in real time. This can be seen by all participants at any time. Average practices score for screening and management practices through September 2025 was scored quite high, which is 96%. Next, please. Target for coaching, especially for these three provinces, Honiara, Guadalcanal, Malaita, is for 804 staff. Those that are completed diabetic screening and management, our target is 86%, which is 695 out of 804. Based on our distribution for Honiara, it's 80%, which is 120 out of the target, which is 150. For Guadalcanal, it's 80%, 195 over 243 for Malaita. Pardon me, for Guadalcanal, it's 80%, which is 120 out of 150, and for Honiara, which is 94, it's 94%, which is 380 over 404. Those that completed diabetic food screening and management with our targets is 74%. On our distribution, 71% for Honiara, which is represent 287 workers out of 404. For Guadalcanal, 79%, 119 out of 150. And for Malaita, 76%, which is account for 185 out of 243. Those that completed a diabetic food wound assessment, debridement and dressing for our workers in Honiara, which is 11%, 9 out of 85, which is started in October 2025. Our national facilitators and provincial facilitators, 57 workers, which is 19 for Honiara, 20 for Guadalcanal, and 18 for Malaita. Next, please. Coaching on its own is not enough to change practice. We consulted with primary health care staff to find the common barriers to effective practice. This enabled us to develop an approach that could be introduced more widely. Initially done in one high-functional clinic, which is Mataniko, in Honiara City Council. This is now been done in all provincial primary healthcare clinics. There are 6 elements. First, use of the 5A system to make space and reduce clutter. Second, ensuring that all eligible adults which is 40 years of age or older, receive screening at every opportunity. Third, the development of a production line. When I visited, I must acknowledge the team W.H.O. I thought it's a factory, which they have a very effective production line in the clinic, which they then divide the task between different staff. This improves speed and efficiency and reduces waiting times. Fourth, ensuring that every person receives a food screen at a time as the routine screen. Fifth, the introduction of a new NCD register that follows new evidence-based coaching steps for recording and tracking progress. And sixth, the introduction of a tickler box system for ensuring that all patients needing follow-up each month are identified and called to retain. Next, please. Initial data are encouraging. In the first year after introduction in the primary healthcare clinics in Honiara City Council province, we have seen a significant increase in food screening, numbers of newly diagnosed diabetes, and in those who are receiving screening. This suggests that we are moving towards improving our healthcare quality. Next, please. The data will be centralized to our approach. Previously, we have had very little data available and have not been able to know where we are. We have developed and introduced a surgical database lined with the DHIS2 platform. This tracks hospital admission, classifications, severity, and changes over time. As mentioned, we have introduced a new primary healthcare clinics NCD register. Data from this we will also link with the DHIS2, probably using handheld devices directly from the clinics. We are also conducting annual primary health care clinic, quality of care assessment. This use exists interviews with clients and chart reviews to evaluate the quality of care they received. Practice indicators are used to track progress and to identify gaps for action. Next, please. I must say, scale-up continues to all provinces. We have for 2025 to 2028. It is still early days for us, but we believe we are on the right track. Our surgical problems was also our primary healthcare problem. By strengthening low-level services, we believe we can begin to reduce the burden on our surgical services, while at the same time improving our health outcomes for the people of Solomon Islands. I thank you, Secretariat and the Moderator.
Thank you very much, Solomon Islands representative. It is great to see bringing a real example of the PHC lens to strengthen surgical care. And with that, I'll give back the floor to the moderator.
Thank you very much. With the permission of the chair, we would like to make the presentation on tobacco control and then go for the coffee break, and after that the two presentations will follow. So may I turn over to our Director, Hiro, for the presentation on tobacco control.
Thank you very much, the Chair. And then, so now we are moving on to the discussion on the tobacco control. So I'd like to start again with the Slido. So if you can take a look at the QR on your screen or table, it'll be helpful. So the first question is, when was the last time you saw someone smoking in public places? So many people actually said this week or this month. So that means like smoking is still very prevalent. And it's quite amazing that we are all in RCM. So hopefully that not many people smoking in this hotel. Okay, next. When was the last time you saw someone using an e-cigarette, which is becoming more popular in public places? So it's similar. So this month and this week, I think it's probably less popular than a regular cigarette, but many people have seen either this week or this month someone see someone smoking, vaping in the public places. Okay, next one. What are the key tobacco control achievements in your countries? So I think many member states indicate the e-cigarette registration and strengthening enforcement, which is probably very relevant to the topic of today. Okay. Number 4. So what are the biggest challenges in your country facing the tobacco control? So preventing industry interference and then enforcing tobacco control laws, and also monitoring tobacco use and then policies. I think these are the top. And then actually majority of you are pointing out that industry interference is one of the most significant challenges. Lastly, do you think your country will achieve the regional target of a 30% relative reduction between 2015 and then 2030? Okay, that's great that the majority of us are optimistic, but at least that not majority, I think most of us, but some said unsure, and then someone not very positive. So with this context, I'd like to show just one slide on the trend in tobacco control and tobacco prevalence in the Western Pacific. So can you put up the slide, please? So if you look at the tobacco prevalence trend in our region, new WHO estimate just came out 2 weeks ago, shows the Western Pacific region continues to have the slowest decline in tobacco use globally. Specifically, region is projected to achieve only 12% relative reduction between 2015 and then 2030. So this is much less than 30%, which is the SDG target. And only 8 member states are on track to meet the reduction target of 30%. Australia, Cambodia, Japan, Kiribati, Laos PDR, Nauru, New Zealand, and Republic of Korea. And despite everybody's strong commitment, the midterm review of WHO shows uneven progress, and then it calls for faster and then timely coordination across the policy areas. With this, after the break, we'd like to hear from 2 member states to share their achievement, practical experience, and then strengthening addressing any remaining gap in tobacco control, contributing towards the 2030 SDG target. Now back to you, DPM.
Thank you very much. Chair, we will end here and we'll have 2 presentations after the break for your consideration. Thank you.
Thank you, Dr. Mercado. We will now suspend this item and break for coffee, and we will resume consideration of this agenda item at 10:45. So enjoy your coffee break before we come back.
As we come together to serve our communities, this is a reminder that any participant in this event must abide by the Code of Conduct we bear to harassment at WHO events. We have zero tolerance for sexual misconduct. If you have any concerns or suspicions about sexual misconduct that may occur during this event, please report directly at investigation@who.int or through WHO's Integrity Hotline. Protecting communities, members of our workforce, and collaborators is a priority to the World Health Organization.
Welcome back. First, allow me to remind delegates that for interpreters to faithfully convey their message to non-English speaking delegates, it is preferable that interpreters receive interventions in advance. Please forward your speaking notes to the Secretariat in time before taking the floor. These can be submitted to capital W, capital P, capital R, capital C, capital M, interventions@who.int. Now we will resume our consideration on agenda item 14, and I'll hand the floor back to Dr. Mercado.
Thank you very much, Chair. We will continue now with presentations from member states, and Dr. Hiro will call them.
Thank you very much, Chair and DPM. So now we'd like to hear from Hong Kong SAR, Dr. Fan Yan, Controller of Regulatory Affairs Department Health, Hong Kong SAR, China, to give us their experience on tobacco control. Over to you.
Thank you for the opportunity for me to share Hong Kong, China's recent experience in tobacco control. Next, please. Our tobacco control policy fully aligns with the WHO FCTC and the Empower implementation framework. Over the past 5 years, we have implemented a series of control measures. In 2022, after a 3-year legislative efforts, we implemented a ban on the import, manufacture, distribution, and promotion of e-cigarettes and heated tobacco products. In 2023 and 24, we increased the tobacco tax by 31% each year. These tax hikes were immediately followed by a surge in the use of smoking cessation services. Earlier this year, we introduced another major bill containing several important measures, including a ban on flavored tobacco products and mandatory plain packaging to reduce the appeal of tobacco products. We also expanded smoke-free zones to cover all public transport waiting areas, queuing zones outside entertainment and sports grounds, and entrances to schools and healthcare facilities. These measures protect the public from secondhand smoke and reinforce the norm of smoke-free public spaces. To combat illicit trade, we introduced a duty stamp system for conventional cigarettes, along with enhanced penalties to increase deterrence. We are also further restricting the possession of e-cigarettes and heated tobacco products to reduce circulation and personal use. Next. Enforcement of the e-cigarettes and heated tobacco product ban is a joint effort between the Department of Health and the Customs and Excise Department with police support. We maintain a zero-tolerance policy. We have removed thousands of online advertisements from social media platforms. Last year, we strengthened regulation of nicotine in non-conventional tobacco products by listing nicotines in these products as a poison, further restricting personal possession of heated tobacco. Next, please. These measures had last slide, please. These measures have already had a significant impact. The prevalence of daily use of e-cigarettes and heated tobacco products has remained low since the ban, even as usage continues to rise globally. In 2023, the daily cigarette smoking rates in persons aged 15 or above dropped to 9.1%. It was also the third consecutive survey in which we could not reliably estimate smoking rates among persons aged 15 to 19. The last measurable prevalence in this age group was 1% in 2017, strongly suggesting that youth smoking rate has declined to very low levels. Next slide, please. Okay, next, please, I'm sorry. So our school-based survey also supports this positive trend. Among secondary students, e-cigarette use has remained low following the ban. And actually, the 30 days use of conventional cigarettes also dropped to 1%. So these findings give us hope that the smoke-free generation may be within reach. Next, please. Although we have enjoyed success in preventing youth uptake, further reduction in smoking prevalence depend on assisting current smokers to quit. Apart from the annual campaigns to raise awareness about smoking hazard, we launched new initiatives to promote cessation. These include clinical toolkits and training for healthcare professionals to deliver very brief advice within 30 seconds during healthcare visits. During COVID, we introduced cessation services combining telephone counseling with postal delivery of cessation medications. Our annual Quit in June campaigns offer free trial packs of nicotine replacement therapy through community pharmacies and primary health centers. Comprehensive cessation treatment services, including counseling combined with pharmacotherapy or Chinese medicine acupuncture, are widely accessible and free of charge. In our Tobacco Control Office, as the WHO Collaborating Center for Tobacco Dependence Treatment, continue to build capacity for cessation support among local and regional partners. Of course, challenges remain. We face strong resistance from the tobacco industry in every legislative process, including heavy lobbying of legislators and attempts to sway public opinion. And the recent delay of the menthol ban is a case in point. Therefore, it is imperative that we continue to collaborate and find ways to counter tobacco industry interference. And we also need to share enforcement strategy and intelligence across borders for effective implementation of tobacco legislation. And tobacco and nicotine products are evolving rapidly, and we urgently need technical support to regulate ingredients and new product designs. In our recent legislation banning flavors, we benefited greatly from the experience and assistance from health authorities in countries with comprehensive ban of flavor chemicals. And this experience also underscores the importance of international collaboration. In closing, Hong Kong, China's experience demonstrates that strong coordinated policies can effectively reduce tobacco use, and we are firmly committed to advancing tobacco control and to working closely with our regional and global partners. Thank you.
Thank you very much, Hong Kong, SAR, China. And then you explained very good examples of evolving regulatory measures, robust enforcement, and then leadership in expanding support to quit tobacco. Now, I'd like to move on to Pacific, and then I'd like to hear from a representative from Nauru, Dr. Don Kadia, Deputy Secretary, Minister of Health and Medical Services, Nauru. I understood that they kindly share the video with us now. Thank you.
Mojo and colleagues, to take this time to thank WHO for giving us this opportunity to share with our Western Pacific regional members some of the strategies that Nauru has implemented tobacco control activities. My name is Don Kadir, and I'm the Deputy Secretary for Health and Medical Services. 2025, WHO conducted its third step survey in Nauru. Some of the key findings in terms of tobacco control steps indicators are shown on the table before you. There's been an overall 24% relative reduction of tobacco from 2004 to 2025. Another key finding which I would like to share is the later initiation. The mean starting age rose from 15.9 years in 2004, and now it's sitting at 17.3 years. I'll share with you some of the practical steps that worked for Nauru. The first one was gaining political support. We presented our evidence-based data to our political leaders, where we gathered political support to look at how we could improve our tobacco control strategies. Through the political support, we were able to conduct a legislation review of the Old Tobacco Control Act. And through this legislation review, which we had done also a extensive community consultation with all our stakeholders. And through the consultation, these are some of the key points that was raised during the consultation, which we incorporated it within the amendment to the Tobacco Control Act. One was to raise the legal age from 18 to 21 years. Selling single-rolled or broken packages were banned, and there was a hefty fine. Also, advertising all tobacco products should not be displayed in plain view. It should instead be hidden or behind the counters. And there was a total ban that was implemented by government on e-cigarettes and also on upcoming new tobacco products. Another aspect of the legislation that was amended was the mandatory licensing of importation, distribution, and selling of tobacco products. And to gain this license, this is approved by the Secretary for Health, and the license fees are some of the highest that individuals or businesses have to pay on the island. And we also introduced these fixed penalty mechanisms, which act as a deterrent also, and to avoid going through the court system. Also, we worked with our customs department in reviewing the excise tax on tobacco products, and this was also introduced in the large budget submission. Tobacco taxes are one of the highest revenue earners of government. So we managed to get a 10% hypothecation that for whatever taxes that are collected, 10% of it is directed towards health initiatives. For example, our cancer program, our health promotion programs, and our training of our health workers. We also introduced cessation services through the assistance of WHO. We also had a lot of stakeholder engagement and collaboration with our key partners in order for us to be able to strengthen our enforcement. And also we ran a lot of targeted community programs, so for schools, business houses, and at workplaces, where we shared the amendments that happened and some of the new laws that had come into place. And also we also spoke and shared with the community on the harmful effects of tobacco. So most of these activities that the health department has done has been done in conjunction with a lot of our key partners and key stakeholders, and it's been accumulation over a number of years. So one highlight of that I would like to share now is we did a student rally where students developed a plug which was presented to government, to cabinet, in which the plug requested that government make a commitment that it will meet the targets of decreasing tobacco by the end of 2030. So this was driven by our students, and it was received by the president of Nauru and the cabinet ministers. We also reviewed our health promotion activities on how we interact with the different target groups. So one thing that we noticed that when we are in primary schools, when we give students a lot of information, they basically are not interested in. So what we did is we went ahead and purchased these tobacco interactive models. So we bought these models of infected lungs, a lung filled with tar in jars, and these interactive health models where students can actually come and have a feel of it and be able to at the same time learn from it. And we did these road shows in the communities, and we took it to the schools where students were invited to come and look at these interactive activities and then take an information package for them to take back and sort of have a read through, or we shared with them. So we found this to be very successful because when we display these interactive models in communities, in schools, even in workplaces where the adults were there, it sort of captured their mind, and there was more interaction, more questions that was asked, because people wanted to know what was the cause of this, how someone's lungs could get so bad, filled with dye, and etc. and etc. So this is something that I think we also need to consider on how our messaging is delivered. We tend to assume that one message fits all scenarios, but what we have found out that we need to always get back to the communities, get their feedback, and see what did not work the last time and how we can sort of improve and how we can deliver it better. We also, some of the challenge that we faced, I think, in this entire tobacco control and the strategies that we used is, I think for Nauru being a very small country context, we have always challenged with enforcement, human resources. We have a high turnover of staff, so people who have been trained as enforcement officers tend to move on or to another department, so that's been a challenge for us. Also, in terms of maintaining that stakeholder collaboration, conflicting priorities do come up, so stakeholders sort of go and start to reprioritize on other activities but ways to mitigate that, we have always had this regular monthly working group meetings where we sit down and we just basically discuss and continue to share on ideas and plans on how we can improve on tobacco activities. And with that, I want to thank everybody for listening through my presentation. Thank you very much.
Thank you very much, Dr. Kadia. And your presentation clearly articulated legislative reforms, and then probably more importantly, the very significant community engagement that led to the significant decline in tobacco use in Nauru. Thank you very much. So now I hand it over to UDPM.
Thank you very much. We now open the floor for any interventions, comments, questions. The floor is open. So we're turning it over to the chair now.
Thank you, Dr. Mercado. As I had reiterated earlier on, we will. The time for your speaking will be 4 minutes. I encourage you to condense those 3 agenda items together for your interventions, and. Already on the list is now recognize the representative from Vietnam to be followed by China.
Yeah, thank you, Chair. Vietnam appreciates WHO's comprehensive reports on strongly support to the proposed actions. Hypertension continues to be a leading cause of cardiovascular disease, stroke, and premature mortality. Guided by the Prime Minister's decisions, Vietnam is implementing a national plan for prevention and control of non-communicable disease and mental health disorder, placing the hypertension management at the center of our primary health care-based approach. Our priorities include risk factor reductions, community-based screen and early detections, continued management and treatment, and integrations of digital health tools for patient monitoring. We are adopting the WHO Heart Technical Package to standardize the treatment protocol, streamline patients' pathway, and promote the use of single pill combinations to enhance the adherence. Training for non-specialist health workers is being scaling up nationwide, supported by regular supervisions and quality assessment, with success additions emphasize on strengthening supply chains resilience for essential medicines, enhancing health information system for checking hypertension and other NCD, supporting learning exchange among member states to share a scalable model of community-based hypertension care. And my second intervention is safe surgery. As we all know, all recognize that surgical safety is not only a clinical issue, but also a cross-cutting consensus involving management, leadership and quality assurance, and health system government at all levels. In Vietnam, patient safety and surgical quality have been embedded in the law on medical examinations and treatment and the national hospital quality standards. Importantly, Vietnam has collaborated with Operation SMILE to assess national surgical safety practice and develop a set of hospital surgical safety criteria. These criteria have been integrated into the National Hospital Quality Assessment System and have been implemented nationwide since 2018. Given these complexities of surgical safety, WHO should play a stronger leadership and coordinating role, not only in advocacy, but also in developing comprehensive technical guidance and practical tools to support member states. This includes establishing and monitoring a national surgical safety program, defining core indicators and data standards for the patient safety, integrating safe surgery within the universal health coverage framework, and building leadership and teamwork capacities in surgical service. Issuing updated technical guidance and toolkits for safer surgery and palliative care, facilitate regional peer learning and collaborations. Thank you so much.
Thank you. Call on the representative of China to be followed by Malaysia.
Thank you, Mr. Chair. China appreciates WH.O.'s attention to and emphasis on hypertension control, safer surgery, and tobacco control. We are in agreement with all the concrete measures and requirements outlined by WH.O. China has always attached to a people-centric development concept, paying attention to all three. In terms of hypertension control, first, we have worked out special campaigns with leadership of the government, cross-agency coordination, and a whole-of-society approach in order to prevent and treat NCDs. We have established cardiovascular diseases prevention treatment system. We have continuously improved upon the 4-tier chronic NCD network covering national, provincial, municipal, and county levels. Second, funds have been earmarked to support localities in carrying out cardiovascular early screening programs and comprehensive interventions so as to reduce the risk factors for key populations or at-risk populations. Thirdly, we have leveraged grassroots healthcare facilities to engage in follow-up visits and health promotion. Hypertension has been listed as a special category diagnostic group to enable a longer duration prescriptions while reducing the number of hospital visits. In this way, treatment compliance has also been enhanced as a result of it. Number 4, throughout China, we have carried out hypertension prevention and treatment science education and promotion activities. Those education activities are across the board, across the country. Awareness has been heightened, and treatment rate and control rate have also been improved as well. In terms of safer surgery, first, we have strengthened the institutional rules and regulations with a host of documents such as clinical management of medical technologies, the surgical classification rules at healthcare facilities in terms of catalog management, surgical classification, surgeon authorization and quality control. A host of systems and bylaws have been established at healthcare facilities. Surgical management has been strengthened with higher quality and standardization so as to ensure quality and especially patient safety. Secondly, we have deployed a host of special dedicated campaigns and action plans to improve surgical safety from pre-operative to intraoperative to post-operative steps with a host of risk management procedures and steps with systematic improvement summarized by 15 concrete measures. We are encouraging healthcare facilities to strengthen and tighten up management of all those 15 milestones and KPIs, asking them to be oriented towards problems, improve upon their internal management mechanisms, and ensure surgical safety in a systematic way. In terms of tobacco control, the Chinese government is earnestly implementing the WHO Framework Convention on Tobacco Control in terms of all its responsibilities and obligations. Over recent years, the smoking rate among people aged 15 and above, as well as secondary school student smoking rate, has enjoyed a sustained decline.
In 24 provinces and 254 cities in China, they have come up with tobacco control laws and regulations. In party and government agencies, healthcare institutions, primary school and middle school, they are turned into smoke-free venues, and all sports events are smoke-free events. And also, we set up smoking cessation clinics for Tier 2 and above health institutions, and we crack down on illegal tobacco sales to minors, both online and offline. We intensified efforts to investigate and address illegal tobacco products and strictly control tobacco ads in mass media. Finally, China will continuously promote Healthy China initiatives supporting RCM's and the regional committees' efforts and actions. We are willing to work together with all members in this region to fight against hypertension, tobacco use, and surgery, and promote surgery safety. We believe that communication can help us to enhance health for all. Thank you.
Of Malaysia, to be followed by Federated States of Micronesia.
Thank you, Chair. Malaysia acknowledged the commendable works of the regional office in strengthening effort across the three priority areas: hypertension control, safe surgery, and tobacco control. We observe the steady implementation of the planned activities and the progress outlined in this report. For hypertension control, the progress of hypertension control in the region resonates with Malaysian own experience, where encouraging advances have been made in diagnosis and treatment. Through overall blood pressure control remains below and desired target. The National Health and Mobility Survey 2023 reported a modest decline in prevalence from 30% in 2019 to 29.2% in 2023. The proportion of undiagnosed cases also improved, decreasing from 14.1% to 11.9%. Among those diagnosed, 91% are receiving treatment with blood pressure control, showing progress from 45% in 2019 to 48% in 2023. This outcome reflects the impact of Malaysian ongoing reform under the Health White Paper, which prioritizes policy reform, community empowerment, and health system transformation. This agenda is being operationalized through the National Agenda for Healthy Malaysia, a whole of government and whole of society movement to to promote healthy living and further reinforced by the National Strategic Plan on NCDs to address shared risk factor in integrated manner. For safer surgery, Malaysia has strengthened its surgical safety by aligning with global initiatives like the Safe Surgery, Save Life program. All hospitals are required to use the initiative checklist to prevent errors, such as performing the wrongdoing surgery. This is further supported by Malaysian patient safety goal, which track key national indicators like wrong surgery and unintended routine surgery item. To improve surgical outcome, the country also monitors the pre-operative mortality rate and surgical site infection. These efforts are part of the broader Global Surgery 2030 vision. Continuous training, audits, strong leadership, and collaboration among different medical teams are essential in promoting safer surgery care nationwide. For tobacco control, Malaysians' adult smoking prevalence declined from 23.1% in 2011 to 19% in 2023. But this progress is offset by rising e-cigarette use 0.8% to 5.8% and dual use 0.8% to 3.9% in the same years. This trend presents a new significant challenges to tobacco control efforts. To address this, Malaysia is advancing towards a complete ban on this use and sales of e-cigarette or vapes, following this phased implementations of the Control of Smoking Products for Public Health Act 2023 that began in October 2024. Alongside this regulatory measure, Malaysia has strengthened prevention efforts through Lung Health Initiative, school-based program, media campaigns, and community outreach to raise awareness of the harms of smoking product. Our goal is clear: to build a healthier, smoke-free future for all Malaysia. Thank you, Chair.
Thank you, Malaysia. Now recognize the Federated States of Micronesia, to be followed by the Philippines.
Honorable Chair, esteemed colleagues and partners, the Federated States of Micronesia welcomes WHO's renewed vision for the Western Pacific region and strongly support the call for a bold, focused action to accelerate tobacco control. In FSM, tobacco use remains a major public health and development challenge, with adult smoking rates exceeding 35% in some states. This burden threatens our workforce, our families, and our future. FSM is aligning with the Regional Action Plan through the following key interventions: regulating by banning e-cigarettes in some states, mandating plain packaging and raising tobacco taxes to reduce affordability and fund health promotions, setting a national target to reduce tobacco by use of 30% by 2030, piloting tobacco-free islands under the Healthy Island Initiative, integrating quit services into NCD clinics and outreaches, multi-sectoral collaboration and community engagement in compliance monitoring and tracking progress, monitor industry tactics and guide policy through regular surveys and a national dashboard. On hypertension, it is a growing and silent threat in the Federated States of Micronesia, especially in rural and underserved communities. We welcome WHO's regional target to bring 100 million more people under blood pressure control and fully support the goal of reaching a 50% control rate across the region. FSM supports this initiative by implementing the following recommendations through some of the following interventions. That's standardizing protocols, training frontline workers, ensuring access to validated blood pressure devices, expanding screening via mobile outreach, workplace campaigns, education and awareness utilizing culturally tailored awareness materials, pooled procurement with Pacific partners, integrating antihypertensives into our essential medicine list, and insurance schemes, conducting step surveys, enhanced facility level reporting, frequent refreshers and cross-trainings on hypertension management and treatment, keeping the national NCD strategy updated and relevant. Unsafe surgery, our remote islands geography poses major challenges to timely surgical access. Yet, essential procedures, especially for maternal health, trauma, and infections, are life-saving and cost-effective. FSM supports the recommendations provided through the following interventions. That's integrating surgical care into our National Health Service Package, developing a national strategy for safe and affordable surgery aligned with the ECO framework, strengthening facility-level leadership by empowering hospital directors and clinical teams to foster safety, accountability, and continuous improvement, adapting WHO's governance training to our context, enhancing quality control measures like sterilization audits, infection protection bundles, with improved early detection, community awareness, and transport logistical for outer island population. We call on WHO and partners to support FSM in legislative reforms, enforcement training, peer learning across the Pacific. And we also seek assistance in developing a national investment case to demonstrate the economic and health gains of tobacco control. Together, let us act decisively to protect our people by building a healthier, tobacco-free, and hypertensive, resilient Pacific with quality, affordable, and equitable healthcare service packages for all. I thank you, Chair.
Thank you. I'll call on the representative of Philippines to be followed by New Zealand.
Thank you, Chair. The Philippines reaffirms its strong commitment to advancing the Regional Action Framework for Safe and Affordable Surgery 2021 to 2030 and the Regional Action Plan for Tobacco Control, consistent with our pursuit for universal health coverage and sustainable development goals. On safer surgery, the Philippines has operationalized the WHO Safe Surgery Checklist through Department Circular Number 2021-0576, institutionalizing standardized pre, intra, and post-operative safety protocols across all levels of care. Recently, the Philippine College of Surgeons submitted to the Department of Health their proposed national surgical plan with emphasis on access to safer and affordable rural surgery. The 7th Ministerial Patient Safety Summit, convened in Manila in April 2025, catalyzed regional consensus on strengthening governance, leadership, accountability, and integration of patient safety within national health strategies. Through the Safe and Sound Patient Safety and Quality Improvement course under the Department of Health Academy, capacity building of patient safety officers is being scaled up. Patient safety indicators are embedded in the health facility profiling system to support continuous quality monitoring and benchmarking. Through the healthcare provider network, surgical referral pathways are being optimized to ensure timely access, reduce perioperative mortality, and reinforce system resilience. On tobacco control, the Philippines remains fully compliant with the WHO Framework Convention on Tobacco Control, guided by the National Tobacco Prevention and Control Strategy 2030, fiscal and regulatory measures anchored on Republic's Acts 9-11, 10351, 11346, 11467, and 11900 have reduced smoking prevalence, increased price elasticity through excise taxation, and sustained revenue flows for the Department of Health's Health Promotion Bureau, the National Health Insurance Corporation, and universal health coverage implementation. Enforcement of smoke-free environments, graphic health warnings, and prohibition of flavored products and smoking cessation clinics continues to expand. The Philippines remains fully committed to integrated approaches to safer surgery and tobacco control, critical enablers of regional health security and population well-being. Thank you, Mr. Chair.
Thank you, Philippines. And now call on the representative of New Zealand to be followed by Japan.
Thank you, Chair. Distinguished colleagues, with regard to item 14.4, New Zealand welcomes the midterm review of the Regional Action Plan for Tobacco Control and the call for bold, focused action to accelerate reductions in tobacco use across our region. We share that urgency and commitment. New Zealand is proud that we have exceeded the 30% relative reduction target by 2030 laid out in the plan. In fact, our adult daily smoking has more than halved since 2015 and now stands at 6.9%, the lowest in our region and within reach of our own Smoke-Free 2025 goal of having fewer than 5% of adults daily smoking by the end of this year. We've been particularly successful at preventing young people from starting smoking. Among 15 to 24-year-olds, the rate is now 3%, and among 14 and 15-year-olds, it's just 1.2%. For our Indigenous Māori population, daily smoking has dropped more than 60%, from 37.7% in 2011-2012 to 14.7% in 23-24. For Pacific peoples, rates have also dropped significantly, from 22.6% to 12.3%. This progress reflects a sustained and comprehensive program over many years: smoke-free environments, plain packaging, large graphic warnings, mass media campaigns, and cessation support. But let me be clear, harm reduction approaches, particularly access to vaping, has also been a significant driver of our recent reductions in smoking. Many New Zealanders have switched from smoking to vaping, accelerating declines in smoking rates where the burden was greatest, particularly for Māori and Pacific populations. At the same time, we are equally clear on the need to protect youth from vaping and nicotine addiction. New Zealand has recently tightened retail, product and marketing rules, strengthened enforcement, and is working to expand school and community support. Pleasingly, recent data shows regular vaping is decreasing amongst Year 10 students, with daily vaping dropping to 8.7% in 2024 from 10% in 2021. We will keep working to drive these rates down further, and in particular for our Māori and Pacific populations where rates are higher. Chair, New Zealand fully supports the WHO FCTC best buys of tax, smoke-free spaces, comprehensive advertising, promotion and sponsorship bans, hard-hitting media and plain packaging, and we support appropriately regulated harm reduction measures. We encourage Member States to consider risk-proportionate frameworks that preserve adult access to a range of nicotine replacement options for quitting, including e-cigarettes, while protecting young people, backed by strong compliance and marketing restrictions. We are ready to share our data, regulation and implementation lessons to accelerate effective tobacco control across the Western Pacific. New Zealand remains committed to working with the WHO and partners to reduce tobacco harm for every community in our region. Thank you, Chair.
New Zealand, I call upon the representative of Japan to be followed by Brunei Darussalam.
Thank you, Chair. We welcome the relevant report for the agendas 14.2, 3, and 4. Hypertension is recognized as one of the key risk factors of NCDs, and it can lead to various health conditions and can be effectively managed through lifestyle modifications. We also believe that sustained efforts are essential for addressing hypertension that is closely linked to lifestyle, which necessitates government leadership, including under the national strategy. In Japan, a comprehensive national health policy called Health Japan 21 has been formulated under relevant legislation to enhance disease prevention and health promotion, including specific indicators. As for safe surgery, ensuring safe surgery is a vital issue directly linked to improving the quality of healthcare and patient safety. We would like to once again express our sincere appreciation to the Philippines for hosting the 7th Global Ministerial Summit on Patient Safety in April 2025. Enhancing the safety of surgical care is closely linked to well-managed infection control and AMR measures. In Japan, progress has been made in preventing surgical site infections and standardizing sterilization procedures. We believe there is potential to support other countries through technical cooperation, including capacity development programs on these issues. Promoting safe surgical practices in accordance with the Action Framework for Safe and Affordable Surgery in the Western Pacific Region 2021 to 2030 and weaving health for families, communities, and societies in the Western Pacific region 2025 to 2029 are essential for achieving UHC. With regard to tobacco control remains a key component in addressing NCDs. In particular, reducing the smoking rate and improving protection from exposure to second-hand smoke are crucial elements. Health Japan 21 includes the initiative that promotes multi-sectoral collaboration and comprehensive awareness-raising activities. For example, on World No Tobacco Day this May, Japanese researchers and international students shared experiences and discussed tobacco control efforts in their respective countries. WHO Tobacco Laboratory Network meeting will be held at the National Institute of Public Health in Japan, which has been designated as a WHO collaborating center on tobacco testing and research. We continue to work on strengthening the capacity for tobacco product research based on WHO Framework Convention on Tobacco Control. While we recognize that flexible approaches in accordance with national context are essential for effective implementation of tobacco control measures, Japan will continue to take appropriate actions to comply with the WHO FCTC. As a country with one of the longest healthy life expectancies in the world, Japan remains committed to actively sharing our experiences and knowledge in government-led efforts and policy on tackling health issues and contributing to health promotion in our region. I thank you, Chair.
Japan, I now call on the representative of Brunei Darussalam to be followed by Indonesia.
Thank you, Chair. On hypertension control, we welcome the renewed global commitment to hypertension control and recognize it as both a clinical challenge and a societal issue that requires action across multiple sectors. Nearly 2 in 5 adults in Brunei live with raised blood pressure, with many remain undiagnosed or inadequately controlled. The Brunei Darussalam Multi-Sectoral Action Plan for the Prevention and Control of Non-Communicable Diseases, BRUMAP NCD 2021 to 2025, provides the framework for our national response, setting clear targets for hypertension screening, prevention, and control. Services are delivered primarily through primary care, with the National Health Screening Program providing nationwide screening for cardiovascular risk factors, including for hypertension. These efforts are further supported by Bru Health, our national digital health platform, which enhances access and continuity of care. Despite multi-sectoral efforts, challenges remain. Achieving optimal blood pressure control demands stronger alignment across sectors, sustained public engagement, and the ability to overcome structural barriers to healthy living. We thus further encourage WHO to create regional knowledge-sharing platforms focused specifically on multi-sectoral NCD prevention, where member states can exchange lessons on food policy reform, healthy urban design, and community-based interventions, and strengthening monitoring and evaluation, which will be invaluable for smaller states. On safer surgery, Brunei Darussalam launched a safe surgery policy based on WHO surgical safety checklist aligned with WHO safe and affordable surgery framework, setting clear standards for infection prevention, safe anesthesia, multidisciplinary teamwork, and continuous monitoring, ensuring safe surgery is not just a clinical practice, but a national commitment. At the same time, we recognize that challenges remain, particularly in further nurturing a culture of safety across all facilities, inadequate training, manpower limitations, hierarchical culture, and appropriateness of checklists. To overcome some of these challenges, support through investments in governance, workforce training, teamwork, communication, and quality improvement has been established and implemented. And finally, on tobacco control, Brunei Darussalam reaffirms its strong commitment to tobacco control as a cornerstone of our non-communicable disease prevention agenda. We have achieved a sustained reduction in tobacco smoking prevalence. Despite this, we remain attentive to the emerging trends, particularly the increasing use of e-cigarettes among youth. Brunei Darussalam's tobacco control strategies are aligned with the Regional Action Plan for Tobacco Control in the Western Pacific and are embedded as a key priority within our Brunei Multi-Sectoral Action Plan for the Prevention and Control of NCDs. Enforcement of the Tobacco Order 2005, public education campaigns, smoking cessation initiatives, and fiscal measures, including the excise taxes on cigarettes and vape products, complement our multi-sectoral efforts. Our commitment to upholding the principle of WHO FCTC, particularly Article 5.3, remains unwavering, and we are encouraged that this commitment has received international acknowledgement with the Global Center for Good Governance in Tobacco Control, GGTC, recognizing Brunei Darussalam since 2021 as one of the world's leading nations in preventing tobacco industry interference. We welcome WHO's technical support in areas including evaluation of cessation programs, guidance on taxation and regulation of novel nicotine products, and strengthening capacity for monitoring and enforcement across sectors. Thank you, Chair.
Nak Brunei Darussalam, call on the representatives of Indonesia to be followed by Republic of Korea.
Thank you, Chair. Indonesia recognizes surgical care as an essential service that must be available in every hospital. As of August 2025, nearly 4,000 surgical specialists are serving across the country. Basic surgical procedures are also accessible at the primary care level through the PONET, or Basic Emergency Obstetric and Neonatal Care Program, which enables community health centers to perform essential emergency surgeries. To strengthen emergency and referral services, we have developed an integrated emergency medical system supported by Public Safety Center 119, now operating in 367 districts and cities. This system helps ensure faster response times and better access to life-saving care. Indonesia is deeply committed to promoting safer surgery practices. We have implemented the WHO surgical safety checklist and incorporated anesthesia and surgery standards into hospital accreditation. Strict protocols are followed for patient preparation, sterilization, and post-operative recovery. Efforts to ensure quality and safety are further reinforced through infection prevention, safe use of anesthesia, and continuous capacity building for healthcare professionals. Hospitals conduct clinical audits and monitor key quality indicators such as infection rates, reoperation rates, and emergency cesarean timeliness. Equally important, we also promote clear communication with patients and families, ensuring informed consent and shared decision-making. Through these ongoing efforts, Indonesia remains committed to strengthening the quality, safety, and accessibility of surgical care, and to ensuring that every surgery is performed safely and with dignity for all patients. Furthermore, we recognize traumatic brain injury, or TBI, as a chronic condition with lasting consequences that often remain invisible within health systems, leaving survivors and families to face lifelong challenges. Making TBI a notifiable condition would enable real-time monitoring, help identify high-risk groups, and guide better resource allocation. We are therefore exploring a WHO resolution to recognize TBI as a chronic and notifiable condition, and we warmly seek the support of the W.H.O family in advancing this important initiative. Thank you, Chair.
Now, Indonesia, call on the representative of Republic of Korea to be followed by Hong Kong Special Administrative Region, China.
Thank you, Chair. The Republic of Korea expresses its full support for the shared efforts for resolving the issue with the hypertension. We believe that the Republic of Korea was able to achieve the 80-80-80 goal attributable to the steady implement of the key strategies suggested by WHO. We have started the hypertension management from strengthening the patient-centered primary healthcare system. We have focused more on prevention and management, going beyond simply treating the disease, and expanded our primary healthcare chronic illness management project nationwide, centering the nearest local clinics for individuals based on our national health insurance that is applied to all Koreans. We believe that the strengthened primary healthcare system gets even more effective with the policy on the accessibility to essential medicines, which ensures the continuity of the treatment. In order to make sure patients get steady medications, which is a core element in treating chronic illnesses like hypertension, we lower the out-of-pocket expenses of the patients when they receive the systematic management. Furthermore, we are actively utilizing our digital health technologies in order to maximize this management system. The ongoing pilot projects on untapped medical treatment and telehealth for people in medically underprivileged remote areas facilitate communications between the medical staff and the elderly with less mobility, making possible more preemptive health management in daily lives. Regarding the safer surgery, the Republic of Korea published the Operating Room Patient Safety Practice Guidelines in 2022 to improve patient safety in the surgical field by sharing information on patient safety incidents and best practices, which is conducive to reinforcing the communication among the healthcare professionals. Also, we have strengthened the management of the appropriate use of pre- and post-operative prophylactic antibiotics and the healthcare-related infection surveillance system. We will not stop at this domestic effort, but will continue to support the capacity building of surgical teams in various countries, including the Western Pacific regions, through our international training programs such as Dr. Lee Jong-wook Fellowship programs. In terms of the tobacco regulation, the Republic of Korea has started to set the graphic health warning system on cigarette packs with 50% of the coverage and expanded it to 12 types, along with the designation of all indoor public facilities as smoke-free zones. Korea is also proactively addressing the issue of new types of tobacco products. Liquid products containing synthetic nicotines are rapidly spreading on the market, and a bill to classify these as tobacco products is currently under discussion in the National Assembly. According to recently released statistics, the adult smoking rate in Korea gradually declined after 2015, but has since increased again with the introduction of various tobacco products. This highlights the need for greater efforts from us. We will use this challenge as a momentum to further strengthen our anti-smoking policies and overcome these challenges together with all member countries present here. Thank you.
The Republic of Korea, now calling the representative of Hong Kong Special Administrative Region, China, to be followed by Singapore.
Honorable Chairman, Hong Kong, China would like to express our appreciation for the excellent efforts of W.H.O. and W.H.O. in tackling hypertension in the region. Like many other countries and jurisdictions, Hong Kong, China is facing the burden of hypertension and its associated complications, as well as an increasing threat of NCDs. According to our recent population health survey, almost 1/3 of persons aged 15 to 84 were affected by hypertension, and nearly half of them were undiagnosed. Hong Kong, China places hypertension control at the top of its public health agenda, integrating its management into our comprehensive strategy to combat NCDs. With concerted efforts from the whole society, our age-standardized prevalence of hypertension has decreased gradually in the past decade. Our anti-hypertensive strategy hinges on two main core pillars. First, advancing primary health care, and second, by fostering healthy lifestyles. Hong Kong, China has recently taken significant steps to strengthen its primary care system. Central to this effort is the release of our primary health care blueprint, which sets out a strategic roadmap towards establishing a primary health care system that aligns with the evolving health needs of the community. Under the renewal of the primary care governance, Hong Kong has introduced a community-based chronic disease co-care pilot system, a scheme which subsidizes Hong Kong residents aged 45 and above to undergo screening for diabetes, hypertension, hyperlipidemia, thereby achieving the goal of early prevention, early detection, and early treatment. Complementing our primary care efforts, we have adopted a life course and setting-based approach and rolled out population-wide interventions to guide healthy behaviors. Moving forward, the Hong Kong government will continue to step up efforts and take a proactive approach in the prevention and control of NCDs through multi-sectorial actions targeted at reduction of risk factors such as hypertension and tobacco use, and strengthening health services to foster a health-enhancing environment. Thank you, Chair.
Thank you. I'll now call on the representative of Singapore to be followed by France.
Thank you, Chair. I'll deliver the intervention on hypertension control, followed by tobacco control thereafter. Our multi-pronged national strategy for hypertension control combines preventive health efforts, targeted sodium reduction, and close partnerships with industry and stakeholders. Allow me to briefly share Singapore's approach as follows. We have embarked on a sodium reduction strategy that aims to decrease the population's average daily sodium intake by 15% over 5 years. Excessive sodium intake is a key risk factor for hypertension, and its reduction is crucial for hypertension prevention and control. We are driving these sodium reduction efforts through the Healthier Ingredient Development Scheme and Sodium Reduction Pledge, fostering multi-stakeholder collaborative effort. We have also provided grants to support manufacturers in reformulating salts, sauces, and seasonings, which constitute a major sodium source in our local diet. We have also engaged food businesses, including hawkers, restaurants, and caterers, to use less salt, sauces, and seasonings, or adopt lower sodium ingredients. The Health Promotion Board has also embarked on a multi-year public education campaigns to raise consumer awareness. We will also extend Nutri-Grade labeling requirements and advertising prohibitions to key contributors of sodium and saturated fat intake from mid-2027. I will now share on tobacco control. Singapore is committed to accelerating tobacco control as a key best buy intervention to protect public health. First, we have taken reference from the WHO FCTC evidence-based measures. This includes standardized packaging, raising the minimum legal age to 21, and increasing tobacco excise duties by 15% in 2023. These are complemented by measures to prevent initiation of tobacco products through preventive education and supporting cessation through our national I Quit program. This is further strengthened by Healthier SG, where family doctors proactively advise and support patients on cessation. Second, we are proactively confronting the threat of emerging tobacco and nicotine products. Singapore has taken a firm preemptive stance by banning e-cigarettes and other imitation tobacco products to prevent a new wave of addiction, particularly among youth. In the face of a trend of these products being used to deliver even more harmful substances in the region, we have further strengthened enforcement and education efforts against e-cigarettes. Third, we are not doing this alone. In the implementation of our tobacco control measures, the Ministry of Health, Health Promotion Board, and the Health Sciences Authority work closely with agencies such as the National Environment Agency and the Immigration and Checkpoints Authority on Enforcement, and the Ministry of Education and Ministry of Digital Development on preventive education. Tobacco control issues are multifaceted in nature, and effective tobacco control requires coordinated efforts across agencies beyond health ministries. Singapore will remain a steadfast partner in the region's collective effort to reduce tobacco use and save lives. We look forward to learning from other member states' experiences and control strategies. Thank you, Chair.
Naka, Singapore, call on the representative of France to be followed by the Kingdom of Tonga.
Thank you, Chair. Regional Director, Ministers, colleagues, France and its overseas territories have been for a long time committed to tobacco control measures, continuing on and matching WHO's own recommendation. In France, the National Anti-Tobacco Consumption Programme 2023-2027 includes bans on vaping products which are single-use or disposable, flavour regulation, plain packaging for tobacco products and vaping products, and we are also committed to regulating the adoption of new products containing nicotine. In order to further reduce financial accessibility of tobacco products, especially with young people, we've decided that taxes should be increased on tobacco products, and that effort will be maintained. in the years to come. Going down that path, and as part of an interministerial approach, French Polynesia recently firmly expressed itself by voting a country law strengthening control activities, marketing conditions, and tobacco consumption. And this includes the struggle to restrict use of vaping and nicotine-containing products. This is a trajectory which is inspired by the New Zealand experience and WHO's instructions, helping French Polynesia to adopt a planned cultural strong approach which has had results adapted to the country. This strategy has been strengthened by a ban on importing vaping products over the whole territory to protect youth in particular and prevent the emergence of new nicotine dependency forms. A smoke-free and addiction-free promotion program has also been deployed together with the Ministry of Education and the Youth and Sports Ministry. There will be a STEPS survey to assess the success of this program in 2030. We remain determined to strengthen international cooperation on this subject and share our experience. Thank you.
I call on the representative of the Kingdom of Tonga to be followed by Kiribati.
Thank you, Chair. Tonga takes this opportunity to thank W.H.O. and all those that shared their excellent programs and experiences in screening, diagnosing, and managing hypertension and other NCDs. We're still trying to shift from predominantly hospital-focused management to strengthening primary health care service, which we believe will address the NCD crisis in our country. We aim to standardize and for integration of care throughout all healthcare facilities and ensuring proper referral pathways in place. The Kingdom of Tonga welcomes the technical discussion on safer surgery and commends WHO for its continued leadership in strengthening access to safe, timely, and affordable surgical care across the Western Pacific region. Tonga fully agrees that there can be no universal health coverage without access to safe and affordable surgery. Essential surgical and obstetrics intervention saves lives by improving maternal and child health, infection prevention, and perioperative care outcomes. Tonga has made significant strides in advancing surgical safety and quality. With WHO support, the Ministry of Health has launched its first National Safe and Affordable Surgery, Obstetrics and Anesthesia Strategic Plan for Tonga 2023 to 2030, a framework that guides the strengthening of surgical services nationwide. Through this plan, Tonga is improving operating theatre safety, infection prevention and control, and the quality of perioperative care. Recent upgrade of Waiala Hospital Operating Theatre was completed early this year to enable joint replacement surgery in Tonga. Surgical services has also been included in the country's package of essential health services, ensuring that resources are planned and aligned with national needs. Lastly, the NSSOP aims to strengthen clinical governance to improve clinical practice and outcome across the country. However, we continue to face challenges. One, shortages of trained surgical workforce and the need to recruit, distribute, and retain skilled professionals across the country. Number two, the need for continuous quality assurance and stronger leadership in the facility level. And three, supply chain vulnerabilities affecting the availability of medical equipment and sterilization capacity. Addressing these issues will allow Tonga to deliver consistent, high-quality surgical services for communities across the islands. To accelerate action, we call for continued WHO and partner support in three areas: comprehensive workforce development, including surgical, anesthesia, nursing, and ancillary teams through training, mentoring, and equitable workforce distribution. Two, technical assistance to implement and monitor our NSOP, is what I call it, and to strengthen quality assurance and clinical governance. And three, sustained investment to ensure that health facilities at all levels are equipped with essential surgical tools and supplies. Chairperson, the Kingdom of Tonga reaffirms its commitment to ensuring that every person has access to safe, timely, and affordable surgical care, bringing us closer to achieving universal health coverage. I thank you, Chair.
Now, Tonga, now call on the representative of Kiribati to be followed by Fiji.
Honorable Chair, distinguished ministers and delegates, Kiribati commends the ongoing work of the W.H.O on this critical agenda item. Chair, tobacco use remains one of the most pressing public health challenges in our region. Despite commendable progress under the Regional Action Plan for Tobacco Control 2022 to 2030, the burden persists. With over 370 million users and more than 3 million deaths annually. In Kiribati, the situation is particularly concerning, with the overall increasing of tobacco use in any form from 49.9% in 2015 to 61.7% in 2024. Chairman, this is an alarming rate. But Kiribati is committed to reverse this trend. As a signatory to the W.H.O Framework Convention on Tobacco Control, we have aligned our national strategies accordingly. We are currently undertaking a taxation modeling exercise with technical support from W.H.O to reduce the affordability of tobacco products. We will improve and increase awareness as well as support communities in their efforts to reduce the use of tobacco through the establishment of the Kiribati Health Promotion Foundation. I am happy to say that next week I'll be traveling with my team to Melbourne to visit the Vic Health Promotion Foundation to study and talk with them on their model. In support of this, we are strengthening licensing system, enforcing minimum age restrictions, and restricting tobacco marketing and use of tobacco in public places. Our Comprehensive Tobacco Control Bill 2025, which will go into law from next year, include banning of e-cigarettes and other critical measures, which I believe these will accelerate our efforts to reduce tobacco use. Kiribati reaffirms its commitments to intensify implementation of WHO Best Buy measures to regulate and ban newer tobacco products and strengthen multi-sectoral collaboration. We call on all member states to take bold, coordinated action to accelerate progress toward the regional targets of a 30% reduction in adult tobacco use by 2030. Chairman, distinguished delegates, together we can protect our communities, especially our youth, from the harms of tobacco and build a healthier future for the best people. Thank you.
Kiribati, I call on the representative of Fiji to be followed by Australia.
Thank you, Chair. Honourable Chair, distinguished forum members, Fiji acknowledges the Secretariat's update on the technical discussions agenda. Our response today covers the 4 items under agenda item 14. On the use of AI, we note the progress in the use of AI in healthcare by member states. We have established our digital health strategy 2023-2027, and we consider AI to be an enabler for health services delivery. We wish to learn more on the governance, application, feasibility and risks, ethical oversight and scalability where necessary on the role of AI in healthcare to better inform our further actions in the responsible adoption of this capability. We look forward to WHO guidance in this health development. On hypertension control, Fiji supports the Secretariat's proposal to include hypertension in next year's RCM agenda. Fiji supports the Western Pacific Regional Action Plan for NCDs, aiming to reduce the premature mortality from NCDs by 1/3 by 2030. Over 30% of adults aged 25 to 64 in Fiji live with hypertension, with a significant number unaware of their condition. Hypertension frequently coexists with other NCDs, such as diabetes and heart disease. We have customized PEN into the cardiovascular risk assessment and management protocol, or the CREM protocol, currently rolled out nationwide. The CREM guideline is aligned to our nephrology guideline, diabetes guideline, and cardiovascular guideline, and it integrates screening, absolute cardiovascular risk scoring, blood pressure monitoring, lifestyle counseling, medication algorithms, and referral pathways. We acknowledge JICA's support for the implementation of motivational interview to support behavior change for hypertension, and have so far trained more than 500 healthcare workers across the country in motivational interview techniques. We look forward to the support of WHO and partners towards our implementation of healthy setting initiatives and the wellness promoting clinics. The outcome of our recently completed STEP survey will further guide actions on NCD risk factors in our population. On safe surgery in the region, Chair, Fiji supports the action framework for safe and affordable surgery in our region 2021-2030. We call on WHO and partners to continue to support member states in strengthening surgical leadership, sterilization, surgical policies and guidelines, and surgical capacity building. Fiji supports the proposed actions in the report and will continue to explore the nexus between surgery and primary health care through the Essential Services Package framework. In the coming week, more than 100 surgical practitioners from the Pacific, who are members of the Pacific Island Surgeons Association, PISA, together with the G4 Alliance, will be converging in Suva, Fiji, for a learning and information sharing forum for surgeons from across the region. On tobacco control, Chair, Fiji supports the Regional Action Plan and invites WHO and partners to support ongoing efforts by member states to address tobacco use. Fiji has initiated its process for the review and further strengthening of our current Tobacco Control Act to address emerging challenges of e-cigarettes, heated tobacco products, and other emerging tobacco products. Excise tax on tobacco remains high, and our ministry is working closely with the Office of Public Prosecution in Fiji on strengthening enforcement, and will continue to collaborate with our partners to further advance tobacco control and enforcement actions. I thank you, Chair.
Naka Fiji, I call on the representative of Australia to be followed by Papua New Guinea.
Thank you, Chair. Thank you also to the Secretariat and to Member States for their informative presentations this morning. Australia is encouraged to see the Western Pacific regional vision reflected in the technical discussions on all topics, demonstrating its influence on regional dialogue and decision-making. On tobacco, we note that its use remains one of the largest preventable causes of death and is a leading contributor to non-communicable diseases. We note with concern that despite steady progress, the Western Pacific region contributes to nearly half of the world's tobacco-related deaths. Australia welcomes the actions proposed in the technical paper, which align closely with the core principles of effective tobacco control, as outlined in the WHO Framework Convention on Tobacco Control. Alongside the FCTC, we consider the WHO Regional Action Plan for Tobacco Control in the Western Pacific an important tool to facilitate strengthened implementation of tobacco control measures within the region. The articles of the FCTC and the guidelines for implementation have provided the foundations for Australia's tobacco control measures. Australia's experience is that a multifaceted whole-of-government approach to tobacco control is most effective, as recommended in the technical paper. Tobacco control requires a continued focus by governments over the long term to ensure it remains on the agenda of national health policies and progress is not lost. Evidence from Australia and overseas shows that when tobacco control efforts stall, so does the decline in smoking prevalence. We acknowledge the challenges many governments face in remaining vigilant and managing efforts to address nicotine products, such as e-cigarettes, while maintaining momentum on effective tobacco control measures. The rapid evolution of these products highlights the need for robust, adaptive policy responses and ongoing collaboration. Although we must be careful not to be distracted by e-cigarettes and other novel products at the expense of implementing effective tobacco control measures. We commend the efforts of all Member States and encourage continued focus on implementing the actions proposed in the technical discussion paper and the regional action plan. We hope for productive discussions at the upcoming FCTC COP11 in November in protecting present and future generations from health, social, environmental, and economic consequences of tobacco consumption and exposure. Thank you.
Australia, I now call on the representative of Papua New Guinea to be followed by Cambodia. Thank you. He's running back.
Thank you, Honourable Chair. Papua New Guinea aligns itself with WHO Western Pacific Region's agenda on safer surgery, tobacco control and hypertension control, and commends the Secretariat for its continued leadership in advancing these vital public health priorities across our region. We also acknowledge and commend the remarkable efforts of Member States as reflected in their comprehensive presentation for driving progress and innovation in these areas. PNG, safer surgery remains a national priority and cornerstone of our universal health coverage and health system strengthening agenda. In May 2025, our National Executive Council approved the National Surgical Obstetrics and Anesthetic Policy, providing a coordinated national framework to deliver safe, affordable, and accessible surgical and anesthetic care for all Papua New Guineans. Under this policy, we reached two historical milestones this year: the first ever kidney transplant and the first cardiac surgery, a coronary artery bypass grafting, procedures marking a new era in our nation's surgical capacity in clinical excellence. Complementing this, the National Health Infrastructure Plan 2025 to 2035 places safer surgery at the center of our health system design, with a strong emphasis on resilient, well-equipped facilities that extend essential surgical services to provincial and our primary healthcare levels. On tobacco control, Papua New Guinea reaffirms its commitment to WHO Framework Convention on Tobacco Control. We have strengthened implementation of the Tobacco Control Act 2016, and we are finalizing its regulations. In May 2025, the government took decisive action to ban the sale of e-cigarettes in the country, an important step in preventing new forms of addictions, particularly among our children. Hypertension and other non-communicable diseases continue to pose a major health burden for our people. We recognize the urgent need for stronger prevention, early detection, and management. Papua New Guinea is keen to learn from Member States' experiences and best practices in hypertension control, including community-based and primary care models, to guide our national response and interventions into our healthcare system. PNG remains steadfast in advancing the agenda of safe surgery, tobacco control, and hypertension prevention through regional collaboration, shared learning, and continued partnership with WHO and our developments partners towards a healthier, stronger, and more resilient Western Pacific region. Thank you, Chair.
Nak Papua New Guinea, and I'll call on the representative of Cambodia to be followed by Niue.
Honorable Chair, Excellency, ladies and gentlemen. Congratulations to Member States for sharing experience and best practice on hypertension, safe surgery, and tobacco control this morning. I would like to make intervention on tobacco control. Cambodia reassures its commitment to reduce tobacco consumption. The National Cancer Control Plan 2025-2030 set a target of at least a 30% relative reduction in all forms of tobacco use. Cambodia has implemented W.H.O. Empower measure, which has contributed to significant success in tobacco control. National laws such as the sub-degree on ban indoor smoking in all workplaces and public places has undoubtedly played a key role in this reduction of tobacco smoke exposure. Cambodia continues its persistent effort to implement Empower through multi-sectoral mechanisms. The National Tobacco Control Committee plays an important role in implementing Tobacco Control Action Plan, supporting law enforcement, and achieving progress include. In collaboration with the Ministry of Tourism, many smoke-free tourism city has been declared. Implement 55% pictorial health warning on cigarette pack since 2016, and plan to enlarge size to align with other member states. Ministry of Health has strengthened tobacco cessation through primary health care. With support from W.H.O. and other development partners, the National Center for Health Promotion has conducted training to 20 referral hospitals and 625 health centers. In 2024, the Ministry of Economy and Finance adopted an excise tax reform framework 2024-2028, which includes tobacco products. Samdech Prime Minister of the Kingdom of Cambodia included e-cigarette to Cambodia negative list of investment in June 2025. Recently, a couple of days ago, on 21st October 2025, the government has issued government order to ban, sell, use, manufacture, and advertising all forms of e-cigarette in the country. Common WHO should have clear guidance on e-cigarette. There are different practices across the countries around e-cigarette, thus making it difficult to regulate, for example, through the national law. Cambodia is ready to move forward with tobacco control and would like to request WHO and DP support to develop local evidence for advocacy on further formulation and law enforcement. I thank you, Chair.
Thank you, Cambodia. I call upon the representative of Niue to be followed by Solomon Islands.
Thank you, Chair. Niue extends its deep appreciation to the Regional Director and the Secretariat for their continued leadership in advancing our shared vision of weaving health for families, communities, and societies in the Western Pacific 2025 to 2029. As a small island nation, Niue continues to face persistent health system challenges, limited workforce, fragile infrastructure, and constrained resources. Yet, we remain deeply committed to strengthening health systems that are inclusive, resilient, and community-driven, grounded in the belief that every life, no matter how few in number, carries equal worth. Earlier this year, Niue successfully conducted its STEP Survey 2025 with the support of the World Health Organization and the Pacific Community SPC. The findings highlight the seriousness of the challenges we face. 1 in 3 adults have diabetes. 4 in 10 adults in Niue live with raised blood pressure. 9 in 10 adults are overweight or obese, and mean blood pressure levels remain slightly above the normal range for both men and women. Chronic diseases are now being diagnosed in younger and younger adults. This is not the prosperity we are seeking. These results confirm a pressing need for stronger prevention, early detection, and lifestyle transformation. To respond, Niue has developed a draft National Health Strategic Plan that sets a clear direction for the years ahead. It focuses on strengthening primary health care and community-based services, implementing standardised treatment protocols through the HEARTS package, expanding access to essential medicines and diagnostics, leveraging digital tools for early detection and monitoring, and building the capacity of our health workforce to deliver quality care. But we also recognise that health is shaped by the choices we make every day. And so, we will be working hard to build health literacy, to educate, to change mindsets, encouraging our people to return to and value our local and traditional foods, to reduce reliance on processed imports, and to rebuild a culture of nourishment rooted in the land and sea. Countries like Niue are low-hanging fruit of regional investment, where even modest support can yield transformative and measurable results. Niue strongly supports the Safe and Affordable Surgery Action Framework 2021 to 2030, and we commend W.H.O for embedding surgical care within primary health care and universal health care. Through partnership with W.H.O and development partners, Niue has made tangible progress, strengthening patient safety and clinical governance at W.H.O Hospital, commissioning a new oxygen plant through W.H.O and the European Union, ensuring a reliable and sustainable oxygen supply, and enhancing infection prevention systems and working to integrate surgical indicators into our health information systems. Our challenges remain real: ageing infrastructure, limited data capacity, and workforce shortages, but our commitment is unwavering. We will continue to strengthen primary-level preparedness, referral systems, and training through regional mentorship, working towards telemedicine. Because for Niue, safe and affordable surgery is not a luxury. It is a matter of equity, dignity, and survival. As a small island state, support to Niue may seem negligible, but its impact is immeasurable. It is essential. In our small community, any loss of life is deeply felt. We must do better. A small investment, such as a commercial kitchen at our national creche, would ensure that every enrolled child receives nutritious meals from their earliest years. And we would hope to extend this to feed our 2 remaining schools, about 500 children in total. This is what meaningful investment looks like: simple, sustainable interventions that shape future generations. In closing, Niue expresses its deepest gratitude to the Government of Fiji for your very warm and exceptional hospitality and generosity, and to the World Health Organization for your exceptional coordination and seamless logistics that have ensured the success of the 76th Regional Committee meeting. I thank all Member States and partners for your enduring commitment to regional solidarity, for considering our request to change the date of this meeting so we may also attend and actively participate. Together, I know we can weave a healthier, stronger Pacific, one built on compassion, community, equity, and collective responsibility. Kawelahi, God bless us all.
Naka Niue. And now I call upon the representative of Solomon Islands.
Honourable Chair, as for the hypertension, we are launching a Solomon Islands intervention to strengthen screening, prevention and management of non-communicable diseases with a focus on hypertension. Using clinical coaching and data-driven quality improvement, we aim to build national capacity for high-quality early detection and management of hypertension within primary health care. Hypertension affects about 26% of adults, and with diabetes driven the leading causes of death such as stroke and heart diseases, roughly 2,000 deaths annually. If we scale up to reach 80% of the population, we could await about
1,171 dates per year and save around USD 25 million in cost from fewer complications. In partnership with WHO, the Ministry of Health will integrate hypertension into the core NCD package, empowering health workers in accurate blood pressure measurement, classification, counseling, and follow-up through coaching rather than traditional training. Hypertension care will be integrated with diabetes and food care under a unified NCD strategy, enabling a whole-of-workforce approach. By 2028, we aim to double the number of people identified and managed for hypertension by 2030. Two-thirds of hypertensive patients and primary care clinics will have good blood pressure control. The program will roll out to key provinces, reach about 960 health workers at 112 health facilities, and impact over 676,000 people. This aligns with the National Health Strategic Plan 2022 to 2032 and WHO NCD targets, and emphasize sustainable, data-driven, locally led improvement in service delivery and reduce hypertension-related morbidity and mortality. As for safe surgery, we are committed to making safe surgery a reality in Solomon Islands, recognizing a strong surgical, obstetrics, and anesthesia services are essential for universal health coverage and for preventing deaths and disabilities from trauma, cancer, maternal emergency, and non-communicable diseases. Our country faces workforce shortages, outdated facilities, and access inequities, with most high-quality surgical care concentrated in one national hospital and remote islands far from timely treatment. To address this, we are developing a national surgical obstetrics and anesthesia plan that will guide long-term system strengthening, supported by postgraduate training, infrastructure upgrades, and regional partnership. Key priorities include expanding training for surgeons, anesthetists, preoperative nurses, and biomedical technicians, upgrading operating theaters, sterilization, oxygen, water, and power, standardizing safety with WHO checklist and infection control, building national surgical data and audit system to track safety and equity, strengthening provincial capacity and outreach, and fostering regional collaboration and public-private partnership. This work aligns with WHO Safe and Affordable Surgery Framework and Regional Action Plan, ensuring safe, more accessible surgical care for all Solomon Islanders, from Honiara to the most remote communities. Chair, I wish to acknowledge our urological team for the historic moment for them in performing their first holmium laser lithotripsy. It is a minimal invasive surgical procedures for kidney stone at our comprehensive medical center yesterday, that is on the 23rd of October 2025. I thank you to the people of Republic of China for this partnership. As for tobacco, we are looking into amending our Tobacco Act and its regulation, controlling affordability and accessibility to keep Solomon Islanders safe from tobacco health-related diseases. We request WHO and our good and great partners for technical support to amend tobacco action plans in achieving our aim to promote health and well-being for our people. I thank you, Chair, and Vinaka.
Vinaka, Solomon Islands. And we will now suspend this item and break for lunch. Before we take a break, may I call on the Director, Administration and Finance, Dr. Landes, for the administrative announcement.
Thank you, Mr. Chair. The lunch is served at the usual venue, and a very short announcement for the attention of the Pacific delegations, as well as Australia, Japan, New Zealand, attending the special event on Healthy Islands Vision on Saturday, 25th October in Yanuta Island. For the delegations leaving today, please be ready to leave from the Sheraton Hotel lobby at 3:30 p.m. as planned. And for delegations leaving tomorrow, please be ready to leave from the Sheraton lobby at 7:30 a.m. Vinaka Wakleu, Mr. Chair.
Thank you, Dr. Landes. And we will reconvene at 2 p.m. Please do come back for the remainder of the agenda item and the closing of the session for the 76 RCM. Nak.